درود و سلام خدمت همه شما بینندگان عزیز تلویزیون جهانی کانال 1. من دکتر نگار متیقنی برنامه امروز طلوع رو خدمتتون با تازه ترین یافته های پزشکی تقدیم میکنم. ما امروز یه مهمان ویژه داریم که قبل از اینکه بریم سراغ ایشون یه خبر خیلی جدید توی نیچر ریپورت شده بود راجع به کووید که من دوست دارم اونو اول با شما در میون بذارم. خبر توسط محققین در دانشگاه ساسکاچوان کانادا منتشر شده و دال بر این هست که در آهوها اینها آنتیبادی ها علیه کووید رو پیدا کردن و براشون مورد سواله که چطور این آهوها در معرض کووید قرار گرفتن. آیا در تماس با انسان بهشون منتقل شده؟ آیا در تماس با حیوانات دیگه بوده؟ یا اینکه حتی آب منطقه آلوده بوده؟ ما امیدواریم اطلاعات بیشتری رو در این مورد به دست بیاریم و حتما با شما در میون بذاریم. مهمان ویژه امروز ما یک جراح پلاستیک و ترمیمی پلاستیک سرجن and reconstructive surgeon از بیورلی هیلز کالیفرنیا هستند، دکتر برنت مالکن. Dr. Moelleken specializes in revisional facial therapy, in revisional facial surgery or erasing signs of surgery while rejuvenating. He has innovated numerous procedures including live fill and LUSIC cheek lifts and the 360 facelift, earning his reputation as the face man. The 360 facelift combines many of his signature procedures and techniques to tighten and rejuvenate the face and importantly avoid the dun look. This is especially valued by patients needing corrective or revision work that comprises much of his practice. Dr. Moelleken has been selected by his peers for the 10th year in a row for Super Doctors in Southern California. This year is very special because Dr. Moelleken was inducted into the Super Doctors Hall of Fame. Dr. Moelleken received his training at Harvard University, Yale University, UCSF, and UCLA. His techniques have been featured in over 60 national and international media outlets and numerous publications. His office is located at Beverly Hills, California, and Santa Barbara. Dr. Moelleken, thank you so much for accepting my invitation.
Well, it's wonderful to be here.
Dr. Moelleken, you are a brilliant scientist, huge inventor. Would you please provide some brief introduction for our audiences?
Well, I'm just a doctor, and I treat patients here mostly in Beverly Hills and also in my other office in Santa Barbara. And I have a family, I have dogs, and I do like to do a little research. So medicine is a nice field because you don't just do what you learned in school and in residency, but you get to innovate, you get to find new things. And when you find new things, it's very exciting because you can offer people things that weren't available before. And plastic surgery is one of the best fields for that, for innovating, because we're constantly changing. I can remember one of my professors, a very famous man, and I was operating with him many years ago, and I said, Dr. Mathis, your surgery is perfect. And he looked at me and he was kind of angry. And he looked at me and he furrowed his brow and he said, by the time you get in practice, and you've been in practice a few years, you'll do everything differently. And sure enough, everything's different. It always changes little by little, but eventually the entire procedure changes. So that's very different from other fields. Plastic surgery is fun because you can innovate. So that's really the crux of it. So in plastic surgery, you get to treat patients and see them through their problems, and often people have a problem that's been bothering them for years. It's been bothering them for years. And in a few hours in surgery, you can help them with their problem and make it better. So as long as the person is realistic about the outcome, not all of us can be Angelina Jolie or Brad Pitt. As long as they're realistic, then people are very happy.
That's wonderful, impressive. That's the reason that you are such an incredible innovator. You have created multiple novel techniques in revision of plastic surgery methods. Would you let us know about the innovation that you have made in these techniques?
Yes. So often when people, for example, let's take one procedure, the facelift. So we all know about a facelift. You go in and people sit, I do it too. I sit in front of my mirror and I say, oh, that looks better. That looks much better. So what the facelift is it's an implementation of those fingers. So these are the magic fingers, and the surgeon needs to produce that in real. So it's real. And so when a facelift is done, what we're basically doing is the modern facelift. We lift the skin parallel to the jawline. So this is the jawline, and we want to lift the skin parallel to the jawline. Now we found out that if you lift the skin up on the side, it changes the direction and it looks very unnatural. And for many years, that has been the way that facelifts have been done. They pick up on the side, but that makes people look done or windswept. So the direction of pull has changed now in some practices. And the direction of pull now is backwards because it's more natural than up on the side. Now this is very important because men have a sideburn. Here's the sideburn. And women have a sideburn too. So if we raise the skin up on the side, the woman will lose her sideburn and it will rise above the ear. And this area will be bald. That's very unnatural. So it's not a good thing to lift the skin up in this direction, but we do need to move up the volume. So we can't move up the skin because it looks unnatural, but we can move up the volume. So that enables us to do what's called a high SMAS facelift. That's a lift of the deep tissue up. So many people hear of the SMAS. Do you do the muscles? They call it muscles. It's not really muscles. It's the deep tissue. It's this tissue that you can grab with your fingers. That we like to lift up in a vertical direction, but not the skin. The skin goes back more in a gentle direction backwards. Now the ear has many features to it. And you may think, oh, it's just an ear, but it's not. It's a very important structure. So the ear has a tragus, the bump in front of the ear. And this tragus should be very relaxed when surgery is done. It shouldn't be pulled forward. If it's pulled forward, it will look very done. It will look too tight. It will look as though the wind is blowing quickly against the patient. And the earlobe should be an earlobe. So the earlobe just sits naturally. It's minding its own business, not causing trouble. So you don't want the earlobe to be pulled down. That's called a pixie ear. And that comes from too much tension and from not anchoring. And this is a new thing that we have where we can anchor the ear all the way around the ear with stitches that hold down the ear and prevent it from pulling down. Behind the ear, we want to go back in the hairline, but the hairline should be matched up. So many ladies now, and men, even men wear ponytails, right? Sometimes you never know. So if you're wearing a ponytail as a lady, you don't want everyone to see your scars. So if the scars are cleverly done and they're done matching up the hair, people can't tell, they can't see that you've had surgery done. So avoidance of detection, that is a key in facelift surgery. And that didn't used to be the case. It used to be, and still is in most practices, people lift on the side. And when they lift on the side, you can always tell because the sideburn will get high. Not a good thing, in my opinion. It's better to pull back in a natural direction. You're still pulling back, you're still tightening, but you don't leave signs behind that you're tightening. And that's much more natural. And people now are looking for a more natural look. So we have many stars, of course, in Beverly Hills. Many of the celebrities come and have their surgery done, and they're always on television, or they're on the red carpet, or they're giving interviews. And gosh, they can't even get a cup of coffee without someone photographing them. So it's very important for them to look as natural as possible. And that's what our goal is in treating them, having them look as natural as possible. So what have I come up in my practice with that helps that? Well, anchoring of the earlobe all the way around the earlobe helps the earlobe to stay natural looking and not pull down. The midface is the area, it's sort of the band that goes all the way across here. This is the midface. And the midface never used to be addressed. It wasn't invented. It just wasn't invented. So it is now possible, and I've published some papers on this, to take the lower eyelids and lift up on the tissues without changing the eye shape. And the reason I came up with this operation is when I was a young doctor in Beverly Hills, everybody who came in had their eyes done, and their eyes were pulled down. Their eyes were rounded, and they needed eye drops, and their eyes were uncomfortable and scratchy. So I thought there must be a better way to do the lower eyelids so the eyes don't pull down and so they don't get scratchy. The other thing that happens is sometimes on the corners the eyes pull down and the eyes look very sad. Have you ever had a friend who had their eyes done and they look different? It's still your friend, it's just different. That's why a cheek lift is nice, because it lifts up the tissue. And that's part of the aging process. Part of the aging process is the tissue falls down below the eye. It falls down and a hollow develops below the eye. So that gives people away. Now, many people who have conventional surgery, this area is beautiful. It's incredible. But nothing's been done for the midface, the area below the eye, that band of tissue that goes all the way across, almost like my eyeglasses. That's where the midface is. So it's very important to lift up the midface. And the cheek lift, the USIC cheek lift, has been important in my practice in maintaining eye shape, but also lifting up the tissue below the eye. So that's been an innovation that's really served me well. Now, what else can you do for the face? What else have we come up with? Well, people are putting volume in the face. As the older you get, the skinnier your face. If you've seen the mother next to the daughter, usually the daughter's face is full, and the mother's face is normal, and the grandmother's face is very thin. Much of the fat has gone away. You see everything in the neck. That's just a normal aging process. So one of the things I've come up to combat that is to place volume in the face, but not fat injection. It's strips of the patient's own tissue. You don't aspirate it. You don't put it in a centrifuge. You don't inject the fat. That's fat injection or fat transfer. So this is strips of tissue placed into the face. Now, let's say I were doing surgery on myself now. There is the patient, Dr. Moelleken. What would you like? Well, my face is very hollow because I'm getting old. So we would take live fill, strips of tissue, taking from the lower part of my abdomen, and I put them into the nasolabial fold area. I might put them into the lips as well. Nothing crazy, but just to replace the volume that used to be there. You can put it in the cheekbones, and you can put it in the temporal hollowing. And in some patients, we even put it underneath the eyebrows, because the eyebrows, if you look at older patients, the eyebrow sits on the bone, and there's none of that tissue that's so beautiful when you're young. When I do a cheek lift, I use the live fill in combination with the cheek lift. So you do the cheek lift, but you also place volume in there to replace the volume that's been lost. You can place it in the marionette line here. You can place it in the sublabial sulcus. That's another fair game. So all these areas are new. They're all new. The technique is new. It wasn't done. So even though my professor told me that one day you will do everything differently from what we're doing here today, he told me that, and he was right. I think he would be proud. He's gone now, but I think he would be very proud that I didn't take everything that he did as being perfect. But being a good doctor, you want to change constantly and look at things that can be changed and try to find your own way if that way isn't around. So the 360 facelift is another innovation. And that is, many people who come to me have already had a facelift. And now it may be time for another facelift, or they just don't look the way they want to look. They look done. They look windswept. They look dated. All these things can be helped. And the concept is the 360 facelift. So someone comes in, and it's usually the same problems. Just as I talked about before, the sideburn is high. Not good in a lady if the sideburn is very high. Looks unnatural. You see the bald spot. It looks as though they're wearing a wig, even though they're not. So you lower the sideburn. All the ear structures, the antihelical fold, the tragus, the earlobe, you reconstruct those and make them look natural. So you're tightening the skin, but at the same time, you're making it look more natural, more anatomic, more the way it was originally. So the tragus has to be relaxed. The earlobe has to sit on its own. And behind the ear, you don't want to see the scars. So that's what's involved in the 360 facelift. You're redoing the face, but nothing has ever been done to the mid-face. So you raise up the cheeks underneath the eye, and you raise up the tissue to the side of the eye. That's the Heiss mass. This is the cheek lift. And now you've covered the entire mid-face, the area below the eye. Wasn't done before. So you're thinking of the face three-dimensionally. It's not just two-dimensional. It's not just tighten the skin, but think of it three-dimensionally. And we place volume in, all little bits of volume here, little bits of volume there. Many of the areas I discussed. Sometimes I'll shorten this distance from the lip to the nose, because the older you get, the longer that distance gets. And people don't like it because all they see is the lower teeth. And if you draw a stick figure and you just show the lower teeth, it looks old. So people want to see their teeth again. They want to see their smile. And many people have spent a lot of money on veneers, and their teeth are fantastic, but you just can't see them. So that's why they like to shorten this distance. And we do that right at the base of the nose. You shorten that distance, and suddenly you can see the teeth better. And that goes along very well if you also increase the volume in the lips a little bit. Nothing crazy, not like You know, sometimes you see people and they just did too much in their lips. It's just too much. It looks fake. And mostly their husbands complain a lot, like, don't do that again. So you still can augment the volume and shorten this distance, and then the whole area looks younger. There's a muscle that pulls down on the corner of the lip called the DAO, the depressor, and I don't know how many of your audience know Latin, but anguli means of the angle, oris of the mouth, the angle of the mouth, pulling down muscle. You can take that muscle and divide that, and people don't frown as much. You can take the corners and do tiny little lifts on the corners of the lips so that the mouth is not frowning as much. These are little things, but they make a big difference. The earlobes can get very long. So you can take a little piece out of the earlobe and make it better balanced and not quite so large. And that's done at the same time as I do my facelift usually. It's all part of the 360 facelift. For the upper eyelids, the standard of beauty used to be take as much skin as possible, take as much fat as possible. Not a good idea. It makes people look very vacant. It makes them look older. If you look at young people, they don't have their eyes hollowed out. They don't have their brows elevated too high. So you shouldn't do a brow lift, for example, and make their brows too high. It's unnatural. It's just unnatural and doesn't make them look any prettier or more handsome, just more done. And the done look is exactly what we want to avoid. Now, people think the done look it's an accident. If you have bad luck, you look done. Not true. It's very mathematical. It's like calculus or geometry. Every little area has a reason why it looks done afterwards. So mathematically, you can avoid all those areas, and you can avoid a done look in all the areas. Some people, they think their brows have gotten too heavy. They look tired all the time. People ask, are you tired? Are you angry? But they're not angry, they're not tired. It's just their brows have gotten very heavy. And they're lifting their brows as much as they can, but they get tired. And by the end of the day, just the brows hang down, the eyes are half closed. It's a very tired look. Some men and women are in sales or jobs where they have to deal with the public, or they have to put on a good face. Nowadays, it's very tough. Competition is very hard. And many people judge older people very harshly. They think they're lazy. They think they don't work well. They think they don't have good ideas. So for that reason, many people want me to make them look younger. Not because they want to look younger and fool people, but they just want to look current. They don't want to look old. They don't want to look out of touch. So what do we do for the brows? Well, you don't have to make an incision entirely across the head anymore. Those are the old brow lifts. They cut right through the sensory nerve that gives feeling to the head. Not a good operation, in my opinion. You can go right through the widow's peak here, here and here, right in there. And do two things. One is elevate the brow a little bit. And the second thing is, for people who have a very high forehead, we can go underneath the scalp and make incisions across. That's the tough layer. That's when you hold your hand there and you move your scalp. The thing that makes it not move very much is the tough layer, the galea. So if you release the galea, and you can do it through small incisions, you can take the forehead and make it not so tall. This is especially good for people who have already had a brow lift and their forehead is now too high. You can do what's called a reverse brow lift. And if you want to be really clever, there's a nerve that goes to the top of the head that allows you to feel this area. Many people are numb. So it's better to preserve that nerve. So you can do a hair lowering procedure while preserving the nerve that goes to the top of the head. You don't have to cut it. You don't have to hurt it. And then people can still feel in the top of their head. And in some patients, it bothers them a lot that they can't feel when they've had another surgery, the older type of surgery that goes all the way across the head. So in those patients, we can actually find the two edges of the nerve and with a microscope, put them back together by putting tiny little stitches all the way around. And then the nerve will be able to conduct, and they'll get some of their sensation back. Not all, but some of their sensation back. And that's called microsurgery. And I do that often for nerves that are cut, either by accidents or by surgery. You can put the nerves back together. But of course, it's better not to cut them in the first place. So that's why the nerve sparing, reverse, lateral brow lift is a very popular item. So that's lots of things for the face. You know, there are all sorts of innovations there with the live fill, with the hair sparing, nerve sparing lateral brow lifts, with the Usick cheek lift, with the mid-face treatment, with the three-dimensional look of the face. The neck. So the neck, usually doctors will tighten the muscle. They'll tighten it down below through an incision here. That's sort of the neck lift. And that makes the neck smoother, and you don't see the strings as much in the neck. There's another way of doing it, and that's an interlacing way that goes back and forth, and I prefer that to the just down the center. So I call it the necklace. Now, most of these techniques, they're not really new. Other people have done similar things. This is just one more step. So for example, the graft, the live fill graft that gives volume, for many years, people used a graft that was a little bit different, but it didn't quite work because it had one part in there, the dermis, the tough part of the skin, that wasn't good for graft material. It wasn't good, it was too tight. It didn't move like the face is supposed to move. So by taking that part out and finding an area in the body where there was very good tissue, that innovation turned out to be a good one. That's live fill. I've been doing that for many decades. So that's it for the face. Those are lots of the innovations and how everything is different than it used to be. I guess the last thing I should mention, it's not surgery per se, is the laser. And lasers have had great advances. So the lasers now, we can do in the face. Of course, everyone knows about lasers for the face, the CO2 laser. It's conservatively done, but now you can do the same laser on the neck, the chest, the hands, the arms, the forearms, the chest, the back. All those areas you can now do the CO2 laser because the new computer design allows the laser to hit the skin, but no two hot dots go next to each other. So computer designs it so that the dots are distributed and they're all, it looks like random. It looks like fireworks, looks like fireworks. But really what it's doing is it's putting the laser beam on the skin in a safer way. And that has enabled us to do many different areas, not just the face, but many different areas with the CO2 laser. And we have discovered settings that are safer. They still get the job done, but they're safer than they were in the past. So all these things are innovations. Now that's surgery. Those are things that people, they either have sedation with or they go to sleep with. There are other procedures that you don't need to go to sleep. They're minimally invasive. Minimally invasive means not really surgery, but not just a cream either. Something in between, minimally invasive. So these are real procedures. They really do work. They're not surgery. So often the companies will tell you how great these devices are, and they're just like a facelift. Not really. They do help, and they can help the right person, but they're not a substitute for surgery. So that's important. And the many different categories. You can put the devices on the skin. You can put the devices underneath the skin, like the body tight or the neck tight. You can use radio frequency for energy instead of just heat, radio frequency. Now the devices are attached to a computer, and the computer measures the temperature on the skin, and it measures the temperature inside, underneath the skin, so you don't get too hot when you're doing the procedure. So many of these procedures can be done under local anesthesia or under sedation, maybe a Valium tablet. So those are very popular for patients. They're not ready for surgery yet. They don't want surgery. They're too young for surgery, maybe. Or they just want to try something out before they have surgery. And there are minimally invasive devices. And we have a center, and it's just devoted solely to minimally invasive devices. There are lots of lasers there, radio frequency tightening devices, and those have become very popular too. As long as we tell patients it's not like surgery. It's not the same results as surgery. Surgery is different. It's one order better. And for patients who don't want to have surgery, it's the best option.
Wow.
So that runs the gamut all the way from minimally invasive surgery to the lasers, to the many types of surgery, the many innovations, and that's just the face. Every other area in the body, we have similar innovations. So it's a very exciting field.
That's phenomenal, Dr. Moelleken, really phenomenal, and definitely your incredible innovations are great addition both to science and practice. And I do know that you go beyond the regular practice and you donate your time for reconstructive surgeries also, like cancer patients and American heroes, veterans. So it's beyond Beverly Hills and Santa Barbara. Would you please let us know about the reconstructive procedures that you provide for patients and different situations?
Well, I always say that the cosmetic surgery I do pays for the reconstructive surgery, because reconstructive surgery is like a hobby. So for 20 years, I volunteered at the VA hospital, the Veterans Hospital. And these are people, they're just very wonderful people, very solid, quiet people. They've been through horrible things, just indescribably horrible things. The tragedies they've seen, most of them can't even talk about it. So if I can do some surgery and help them out and make them feel better, and then that makes me feel good. So many of them have been in the sun a lot and they've developed skin cancers. So the skin cancer starts small. It's always best to catch it when it's small. So when you go to your dermatologist or your plastic surgeon and you check out and see if you have any lesions that could be skin cancers, it's best to biopsy anything that's suspicious. Yes, okay, you can maybe spray it once with liquid nitrogen if it's not really suspicious for a cancer. But really, you want to biopsy the cancer and clear it out. Make sure it's cleared out and close it nicely, close it cleverly. So if you take out a mole, let's say you have a mole on the face and the doctor says, I don't like the look of that mole, it may be cancerous. So we have to send it off to the pathologist. Then I like to do surgeries like that because you have a pathologist, you take out the lesion, and I do this either here or where I'm a professor at UCLA. We take out the lesion and we give it to the pathologist and ask him to look at it under a microscope. And he'll look at the edges and tell us whether we have the whole lesion or whether we have to take out more. If we have to take out more, we do it on the spot, and the patient leaves once I've reconstructed everything. Now, one of the ladies I just did today, just did her surgery today, she had a large cancer on her nose, and she's a wonderful lady. She works with disabled children. You couldn't make a more perfect lady. Does very little for herself. So she had a cancer on her nose that was growing, and eventually she came to me. She was very frightened. She was worried about it. She knew there was something bad, but for some reason she just hadn't taken the time for herself. She had lots of time for her children, for the disabled children, but not enough time for herself. And the cancer was very advanced. It took almost the entire nose. So I knew it would be a big surgery. I knew it would be a big surgery. So we talked about it, and she was very worried. Was she going to be a monster when this is done? And that's what people worry about. Will they look like a human being? Will they still be pretty? Will they look like a monster? So we took out the cancer, and when I was done, and the pathologist said, "You're done. All the cancer is gone." Most of the nose was gone. So I had to reconstruct the nose. I had to put little bits of cartilage back where the cartilage was missing. Cartilage is the thing you can twist and push. That's the cartilage. The bone was okay on the top of the nose, but almost all the skin was gone from the nose. So the best way of reconstructing that is using the facial skin. And the best match is the skin right next to where the injury was. So I used large flaps, and I did essentially a facelift in reverse. So instead of taking the skin to the side, I brought the skin to the center and reconstructed the nose. And it was a very big surgery. I don't think she went to work for a month, but it healed up beautifully. And she again felt comfortable going in public and teaching her children. And today she came back and we did a small revision right on the top. There was a scar on the top, which I repaired. It's a very gratifying case. And I have a charity, and I do many of my cases through the charity. So if people can't afford it, or for whatever reason, then we do the surgery through my charity. So we did the surgery today through my charity, and it was very gratifying because she already had a nice result, but now she had a scar on her nose that we took off. Now eventually, we'll put her on the website. She's consented to it, and then everyone can see. Not only to see how well she came out, but to know that if you have a cancer, you shouldn't ignore it. You should have it fixed by someone who's very excited about fixing these things. The longer you wait on a cancer, the more it grows. The roots grow, the stem grows. It's like a weed in your garden. If you get the weed when it's small, it's easy to take out. But if you wait until the weed is large, then you have to dig it out with a shovel, and it's much more difficult. And the same thing with human beings. If you have a cancer that's neglected, then the longer you wait, the worse it is. So come in early. Just get it done. People always feel better once it's done. Your imagination is much worse probably than what will actually happen. And if we're very clever and we take our time and we look at reconstructive surgery is really the same as cosmetic surgery. You want an outcome that makes the patient look human, that makes them look normal. You don't want to distort the anatomy. So that's why reconstructive surgery is really the same as cosmetic surgery. It's the same principles. It's the same goals of restoring someone to a normal, attractive appearance. And even with skin cancers, that's the goal. So many of my cases are like that. Skin cancers in veterans, skin cancers in my patients. Many of them complex. We have to make parts of the nose, we have to make parts of the ear, have to make parts of the lip. And lots of techniques are involved in this, not just surgery, but also lasers. What are lasers for? Well, let's say someone has a burn injury, and we all know what burn patients look like. They have scars, and scarring is very disfiguring. And just as humans, now we're more evolved now, we're more refined now. We don't laugh at people with scars. We don't look at them or make fun of them. But inside, we're programmed to feel an aversion to scarring. We have to fight that, but there's a natural aversion to scarring. So there's a very good reason for repairing scarring in people, to make them look normal, so they don't scare children, so that they can be more confident, so they can go about their lives and not think about their burns. And that's a big part of my practice, is burns. So the lasers are very helpful for that, but also scarring. Scarring can affect patients anywhere there's a burn, even on the arm. Let's say a burn from hot tea or hot coffee. Sometimes that burn can make the skin very delicate, very thin. And if it's thin, it's hypersensitive. So in children or in people who've had a burn, you'll often find them, they'll shrink back. Hey, how are you doing? You reach out to shake their hand, and they'll shrink back. So if you can take a laser and you can reduce the appearance of the scar, reduce the appearance of the redness, you've done that person a great favor. And it's very gratifying for the doctor. That's why I say my cosmetic surgery pays for my reconstructive surgery. So I do like reconstructive surgery. All over the body, you can have problems. You can have cancers, you can have injuries, you can have wounds. And people don't like to show those wounds. They're very self-conscious about them. But you can repair them if you're clever and you move the tissue around and you replace the tissue with the closest thing that the body has to offer. That's not just putting a skin graft on. It may be taking the tissue next to it and moving it in such a way that you can cover that wound with the patient's very own tissue, which looks like his own tissue. That's our goal. Restore the person to as close to normal as possible once we deal with the reconstructive element.
Impressive.
The hands. Go ahead.
You go ahead, please. You can continue.
Yeah. So all over the body. We've just talked about a couple areas of burn patients and of skin cancers and of the face. But I mean, that's plastic surgery now. It's very different, and thankfully we have many more tools than we used to have. And one of my old professors had invented many of the tools that we now use, of taking the tissue next to an injured area and moving it, taking out the injured area or the cancer, and moving the tissue next to it. It's called a flap. So many of those he actually came up with, and I actually helped him. So we were in the morgue, and we would do experiments, and we'd look at the anatomy and make sure the arteries were okay, and then we'd do the flap. And next thing you know, we were doing it in the operating room on a patient, because we had determined the anatomy was okay and the area was okay, and then we do it in an actual patient. There's nothing better than that, than to be in the laboratory to design something, and then a week later you're doing it in a patient and it works. There's nothing better than that.
Very impressive, very incredible and beautiful. During my work at Wake Forest Institute for Regenerative Medicine, doing a fellowship with Dr. Anthony Atala, their team doing a wonderful Department of Defense projects supported, like burns, replacing amputated organs, scars, and many other wonderful regenerative medicine research. How do you envision regenerative medicine field in the plastic surgery, since I have realized during my fellowship that plastic surgeons and surgeons have a key role in moving new therapies to the clinical side? How do you envision the stage of stem cell therapy and regenerative medicine?
Well, innovation in medicine has a bright side, and we love to look at that bright side. We love to look at the innovations and the progress that people have had, and we talked about some of those today. But it also has a dark side. And the dark side is a lot of innovation is driven by commercialism. So as doctors, as responsible doctors, we have to tell patients which of the innovations we think are valuable and which of the innovations are just commercial. So that to me is the big challenge, and a reputable doctor will look back at his career and he'll sit back, or she, and they'll have a big smile on their face because they know the treatments that they offered their patients were valid. They were good treatments, not commercially based, that they're good, effective treatments. Now, people in the lab, like you, their only goal is to do a legitimate treatment. That's their only goal. It's sort of the highest art in science, is to do things scientifically based, and the only goal is to make something legitimate that will help people. That's a very high goal. That's a very high goal. And in an ideal world, all the doctors would have that goal. They would want to just do treatments that help people that were legitimate. So I like to look at the light side of things too. The glass is half full. Some people say the glass is half empty. The glass is half full. So innovations, at least they spark conversation, and you can sort out which innovations don't have merit and which ones do. But my hat is off. I don't have a hat on, but my hat is off to the scientists in the lab. I spent 2 years in the lab, and very tedious work. And you work until your fingers hurt. And at the end of the day, you go to the wall where there are bricks, and you put your one brick on the wall. And that's your contribution. That's science. That one brick on the wall. And it's a real brick, and it's there, and it's your brick, and you're a scientist. So my hat's off to you for doing that kind of work.
Thank you so much, Dr. Moelleken. So impressive information. I should make a confession. I have never undertaken plastic surgery procedures, but honestly today I have been feeling tempted to make a consultation and appointment with you for near future. So do you face with post-pandemic boom in plastic surgery?
Yes, I think there has been a boom. I'm not sure why. People talk about Zoom and Skype and so on, where they see their own face and they don't like it. I think there's something psychological about seeing your own face, but also there are witnesses. Every little box up there is a witness on how you look. So it's not just you kidding yourself how great you look. It's all those witnesses seeing what you see. So I think that may be the Zoom effect. It's the seeing yourself, but also knowing that other people are looking at you too. But also after every tragedy, after every terrible time, after every war, people feel good. They feel good, they live, they made it through. So hopefully we're almost there with the pandemic. And I think some of that optimism is already coming through. So people are saying, I want to get that work done. I want to tune up my face. I want to look like I feel. Life is precious. We know all these people who have gotten sick. We know people who have died. That could have been me. It was a terrible time. And I'm going to live life. I'm going to live life. And that, I think that spirit accounts for some of the, you know, the people wanting to have plastic surgery also.
Thank you so much, Dr. Moelleken, for the wonderful, wonderful information. Our time, unfortunately, is over, and I would love to invite you for the next upcoming talk and discuss more about your slides. And also, I just got curious how these plastic surgery techniques can affect facial recognition technology. So hopefully we can discuss this further in the next interview. Again,
well,
so many thanks.
I would be honored.
Thank you so much. The honor is mine, and again, so many thanks for accepting my invitation and for your time. Thank you so much.
Well, thank you.
بیننده های عزیز، خیلی ممنون که بیننده برنامه ما هستید. در برنامه طلوع با تازه ترین تکنولوژی ها و اطلاعات پزشکی. برنامه ما هر سه شنبه بعد از ظهر ساعت 6 به وقت غرب آمریکا مطابق با 5:30 بامداد به وقت ایران پخش میشه. تا برنامه بعدی و ترجمه این مصاحبه که خدمتتون خواهیم بود، شما رو به خداوند میسپارم. خدا نگهدار.